on, and then as people are signing on, we'll have you put your name, pronouns, organization, and role in the chat, and also tell us something that you're looking forward to this summer. And I think all of you know, but my name is Courtney Kenny. I use she, her pronouns. I'm the Health Equity Manager at Oregon Primary Care Association. And from OPCA, we also have Malia here. We have Tori. We have Stephanie will be coming in and out a little bit. And then we also have Amy joining us today, which is really exciting. And one thing I'm looking forward to this summer, it's funny, I put this question in and I haven't thought about it yet. I would say finding some beach time and some seafood. That combination of things is like just pure joy for me. So looking forward to that. Backpacking and camping trips are popular. Kids finally returning to daycare. That's great. And just the sun. I think we all wait for the sun for an excruciatingly long time throughout the year. So, sun is exciting. Vitamin D, that's hilarious. To folks just joining us, please share your name, pronouns, organization, and role in the chat, and also tell us something that you're looking forward to this summer. And I think we can go to the next slide. Everyone has already done most of these things, so sorry to remind you again. On Zoom, keep your line muted when you're not speaking to help avoid background noise, but please share your camera when you are speaking. We love to see you. So if you're willing to be seen, please have your camera on while we're discussing things. The chat is available for comments or questions. And then if you haven't already, please rename yourself on Zoom to include your organization name next to your name. That really helps us for tracking. And then the session is being recorded. We don't post these publicly, but we like to be able to share with people who couldn't make it. So we have been recording them. Next slide. Our norms, beyond what I've just said, interact with each other in OPCA via chat, or you can raise your hand if you'd like to speak up, be willing to step up and also step back, be present, focused, and not multitasking as much as possible. Of course, take care of your own needs, but I've put away all other things and I really hope that you will too. And enjoy this partnership. This is the last time that we will all be together in a workshop format. There's a few other things coming in the next couple of months, but use it as an opportunity to build stronger ties with your FQHC and CCO partners. We love getting to interact with you all in this way at OPCA, and I hope that you look forward to being able to hang out with everybody with a similar mission and work. Next slide. And of course, this work is only made possible through really generous funding from Cambia Health Foundation. We're really grateful to Cambia. Next slide. So our agenda for today, we just spent a few minutes settling in. I have a few other things to share, and then we'll go right into team presentations. We'll have a 10-minute break after those, and then we will all return, and we're going to do breakout groups by organization today to do post-project surveys, and I'll share more about that when we get there. And then I have some details for our upcoming events to share with you, and we'll do our workshop evaluation using Mentimeter. I know workshop evaluations are not that fun, but I beg you please to stay on because we've added a few questions about our upcoming events too. Next slide. And going into team presentations, next slide again, sorry, Amelia. So we collected all of them from Google Drive between last night, and I did check this morning and it seemed somebody made changes right at 8:50 and we were able to capture those. If you've made changes in the last 15 minutes, please let us know before you start. That way we can capture the new version. Each team has 7 to 10 minutes to present. Please actively listen and ask each other questions, keep the conversation flowing. And we're going to use the same order of presentations that we have been using. So we'll start with Umpqua Health Alliance and Adapt Integrated Healthcare, then Umpqua Health Alliance and Aviva, Care Oregon and Virginia Garcia, Care Oregon and Wallace, and last but not least, CPCCO and Reinhardt. Next slide. And that's all the opening remarks I have. Do we have folks from Adapt Integrated Healthcare and UHA on the line?
Hi, Courtney. This is Debbie. Yes, Alicia and I are here.
Hi.
And I think Tanvir's on too. Yes.
Yes, I'm here.
Awesome. Okay, so I guess for our final presentation for our PowerPoint, this has been, very enlightening, and we've had a great time working with everybody. So I wanted to give a shout out to everybody that participated. Next slide, please. Our team has not changed since the beginning, so that's we've been pretty consistent with that. Next slide, please. Our best practices, things that we had, taken away from this is that having the Z codes attached to the screening questions really does help, get those codes captured, and also, makes the correlation between the questions and the Z codes. And then something that we had found and have tried to implement is kind of having a Z code reference sheet. Early on in the collaborative, OPCA and OHA had a Z code crosswalk of Z codes that were known to be used and how they related to the questions on the prepare. And so we laminated those and had those at our staff's fingertips so that they could see that very quickly. Next slide, please. Looking back, there's a lot of things we probably should have done either quicker, different, or I guess just, kind of an aha moment. But we tried to explain in more detail to staff the importance of including, attaching, documenting the Z codes very early on. But as everybody knows, their staff changes, comings and goings, and then other things that, seem to be on the forefront, the main one being COVID. So just reiterating that all the time. Why it's important, what that looks like, not just saying, you need to do this. And then one of the things, Alicia, do you want to talk about this? She's our risk and compliance officer. So this example is something that, we had that had been brought up to us multiple times.
Yeah. Like Debbie said, we had someone who came and was new to us in the middle of the collaborative, and then another person who was in the same position but left. And like Debbie mentioned, that maybe the lack of explaining the importance, because we got to the end of the collaborative and we were that lack of understanding from that newer staff member, how important it was to capture these or to document them. And so kind of at the end of it, we were, I don't know if you want to say scrambling, but we were trying to explain like how important these were, but we were already, 10 months into the collaborative at that point, and she came in probably about 7 or 8 months into the collaborative. So, like Debbie said, explaining that the importance of what we were doing on this. Looking back, we probably should have done a better job of that.
And they, staff is always taught to, review, clean up problem lists, because
Right.
that creates problems also down the line in other areas. So in doing that, some of the Z codes either got removed or indated, thinking that those were things that may not apply moving forward. And so just again, a better explanation of, a lot of times these codes are ongoing. It's not a one and done. So yeah, that was something that kind of like, again, just came up as, moving through this collaborative, which was,
Right.
which was good for us.
And honestly, we may not have found it had we not already been working on the collaborative. Potentially the staff could have been doing it this whole time. And had we not been working on this, we may not have known. So that was helpful to us too, that we were working on this, that we can understand and help them understand that we're not removing it unless it's really a resolved issue. But like Debbie said, a lot of these are going to stay on long term.
Next slide, please. So our greatest barriers was, again, the education and clinic staff buy-in. You can say we have to do this or we need to do this, but without explaining why, showing how it all, comes back to better patient care and, closing the whole big loop, it doesn't resonate, I guess, sometimes. And then how big a role that our staff does play in applying the Z codes. It's not just the providers that need to attach them. I mean, it's from front desk all the way down that you can, make note of these and say, hey, this needs to be addressed, or let's include this, because it does show total patient care. And then, of course, I hate to beat a dead horse, but our EMR system, learning the new system, has become challenging. We were very, very proud of, the way that we could, capture and send data from our centricity system. That was something that was very forefront for us. And right now we're Ocean Epic is going to be able to do that too. It's just us learning how to do that all over again. So,
Right.
And it's been a barrier for staff trying to get those codes included too. So.
Right. And not knowing where some of the forms are so they can include it. So yeah, that the last couple months has been difficult for us.
Next slide, please. And yes, we will continue to use Z codes. We're very passionate about it. And, this collaborative has only, made us more excited about it. So we will continue to educate and, let staff know the importance, why we're using them, how it benefits them, patients, overall, everybody involved. So we feel that the Z codes help capture the true picture of a patient and can identify areas that may require additional help resources that our clinic and staff can provide. And, moving forward, and Tanvir can touch on this, more than we can, but, payers are looking at that additional information that the Z codes can provide also, because it does help create a truer picture of the patient and how complex that patient can be, and what staff, clinics need to do to help get that patient where they need to be. Tanvir, do you want to elaborate on that from the CCO's perspective?
Yes, I can add a few things to it. We'll give context to the importance of Z codes. I'll take an example of a new program. It's not really new, but we're in the new phase of that program. People may remember it from an Oregon Health perspective and all the CCOs called Prometheus. But now that program has been renamed with a new platform, a Medicaid Efficiency and Performance Program. And that's basically to see how we can cut unrequired services for asthma, diabetes, and SUD, focusing on our claims utilization and the type of services that are being delivered, and any kind of an adverse event which happens in any of these three areas. The whole onus of the program is to create programs and implement those programs and interventions which can avoid adverse events. And when I looked at that, and I've been having conversations with OHA's finance department on this, one of the key things is that some of the factors, or rather all the factors we're looking in that program are clinical for asthma, diabetes, and SUD. But when you look at non-clinical factors, social determinants of health play an important role also in causing either adverse events and in that population, or because of probably one of the main causes is not able to follow directions from their caregivers, their providers, either not being adherent to treatment or things like those can lead to ED visits and hospitalization. So stress on capturing information around SDOH cannot be underestimated. So I think this is an important line of work that we're doing, and it has implications across into other programs as well.
Thank you. Next slide, please. So our next steps are to implement a workflow to incorporate the Prepare into our new EMR system and modify, update the current process for extracting the data. So again, that is kind of a big hurdle for us to get that all up and going, so staff know how to do it, and then how we can get the information out to the CCO and our partners that are also going to help look at the data and get back to us. So anything to add, Alicia?
No, I don't think so.
Okay, so I think that's our last slide.
Oh, you're on mute, Courtney.
Sorry, thanks. Thanks so much for this. This is amazing. And you all, I mean, everyone has done amazing work, so I'm probably going to keep saying that, but you have done amazing work. And does anybody have any questions for ADAPT Integrated Healthcare? They were previously South River, if that helps you fill in kind of the details over the last year, or UHA. Did anybody else try laminating the sheet of Z codes? That one sticks out to me because my clinic used to post reminders everywhere, like everywhere.
What I wanted to do at Wallace, I had made a crosswalk that has the prepare questions and the relevancy codes, and was hoping people would paste it next to their desks.
I'm really excited to hear the excitement around C codes. You know, just even hearing you say, Debbie, like, we're really passionate about this, or Tanvir saying you can't overstress it, is really great to see. And I'm glad that you have found Z codes to be really useful in this space. That's super exciting. And if you haven't found Z codes to be useful, that doesn't mean that we're not excited for what you've done. It's just, it's nice to see that it's a useful tool and that it is providing use. So we, I think, can move on, and we'll have more time for discussion throughout this section. And I'll take us to the next slide. And we'll be hearing from Aviva and Umpqua Health Alliance.
Hello, can everyone hear me?
Yes.
Okay, next slide. So our team's changed a little bit since we started. I came on in October. We have a new VP of Community Health who is in charge of the direction of the SDOH now, along with myself. And other than that, pretty much the same. Next slide. Best practices. So we're really proud of what we came up with within our EHR. We had a really great informatics. We still have a great informatics team. They came up with a great system early on. We initially represented the idea of doing like a paper pilot. They kind of thankfully they resisted that idea and wanted to kind of get it right from the start. That did take a little more time, but we're grateful that of the system they came up with. And it's about creating an order system that allows for grouping of Z codes based on the sections of the prepare screen, is what we use, allowing for medical staff to deselect codes that do not apply rather than having them memorize or keep a sheet of appropriate Z codes. Next slide. So this is kind of like a little screen grab of what it looks like in our EHR. Basically, they will search, so the create an order, they will search SDOH and then they'll see the sections of the prepare. So whenever they do review the screen, they'll see the areas that they score positive on, and then they'll get to select one or all sections, depending on where they screen positive on. And then on the following screen, that's the bottom box here, you can see there's a little X next to the Z code, so they can what we call trash can the ones that don't apply. And then we can always, affirm or confirm that this is the case whenever we review the screens as well. And so it's just a really great system for medical staff so that they don't have to really change a whole lot about their workflow. I mean, they already know how to make orders. So it's nothing that was too cumbersome for them. And I think everyone was happy about that. Next slide. So looking back, we deliberated on paper versus electronic for our screening pilot. We did actually kind of have a hybrid approach. There's one clinic that we went ahead with the paper. And that was because currently the way our electronic process works is most of the electronic screening is being done through pre-check-in. And so we're seeing a difference between the amount of positive screens between the paper and the electronic currently. And that's because those who have the ability and the time to do pre-check-in typically have lower amounts of social determinants than those who come in the clinic and do the paper. So ideally, we'll get to the point where we're doing all electronic. We're capturing, when they come into the clinic, before they come into the clinic, and then if they're not able to complete the screen at all, we'll actually have staff here soon that can make the calls beforehand, either before the visit through phone call, or maybe trying to catch them when they come in and actually conduct the screen in person for those who don't have that ability. Because we've noticed, that the screen is a lot for some people. It's 20 questions. The reading level is not necessarily where it should be. And they don't always understand the questions. So for those that need it, we definitely want to have staff to perform the screen with them. So just capturing the different levels of, aptitude among patients. Next slide. So greatest barrier is working around technology that wasn't built for establishing an SOH program. We were kind of like retrofitting existing systems. So we used the order system, but we got really creative and made it work for us. It was kind of funny because there was nothing that was currently available within our EHR at the end of last year. And so we came up with something. And then just about a month ago, the the company that makes the EHR, they released their version of an SDOH system. So we're going to be trying to incorporate that into what we currently have, and then hopefully be able to provide the feedback to them where maybe that system that they made comes short. Because so far the only thing that informed their system was collecting the screens, not necessarily the follow-up process, because not very many places are going through that follow-up process. So we need them to kind of tweak it, and hopefully we'll be able to inform them to make those changes, because we think that they can be done. It's just maybe they weren't fully aware of what the future is going to be requiring. And then our vaccination efforts delayed some of the higher level decision making, understandably. So next slide. So we will continue to use Z codes. It's useful, reportable data. We can use the data to build our program and improve the care of our patients. We just kind of kept it simple. Next slide. We are hiring additional staff to increase our screening and follow-up efforts. So through the learning of the pilot, I've actually been able to create kind of a charter that gives structure to SDOH work as it stands at Aviva right now. So we kind of have, I've divided into like 4 roles, and it kind of just gives like an idea what a future larger SDOH program will look like. So a lot of lessons learned, and then well, hopefully soon the screening pilot will be officially done, and then we can expand it to all of our patients. Because right now we're doing 4 providers, patient populations. So I think that's it. If there's another slide, maybe, I'm not sure.
I think that's the last one.
Okay.
Thank you. So we have a few questions coming in the chat. So the first one was from Lydia. She asked, is this in Smart Steps, the order flow that you've chosen?
I'm not familiar with that term. We have Athena is our EHR. So I'm not familiar with Smart Steps.
Sorry, I should have realized. Of course, not everyone's on Ocean, so I apologize. It's a epic thing. Never mind.
Oh, gotcha.
And the next one is, we had some conversation about care steps as well, and just how this can link over. And then we have a question from Stephanie. Scott, what roles are you hiring to do the screening? And I know you had mentioned, let's see how good my memory is, that you had mentioned bringing in medical residents, and then also that you were doing work study programs at your local community college. Is that correct?
Yes. So we are hiring, so far the tentative name is a patient navigator. So this person will be kind of in like a, I don't know, like just like the follow-up role. So this person will probably be conducting some screens along with myself, and then doing the follow-up calls. So when we get a referral from a provider after the medical staff has done that workflow, and so they'll be doing the calls. So we're tentatively calling it a patient navigator, and so it'll be me and then that person working on that. And then on the care steps, we've also incorporated that into our follow-up process. So like if it's a transportation, we'll put that in. If it's a community resource, we put in that care step. We can attach those to the orders whenever we receive them. So whenever we make a like a comment on the order, we can type in that care step, and then the magic of the EHR submits it, and so it's been a good process.
That's great, thank you. So, and I actually have one follow-up item. So I think it was in the December workshop. You all had mentioned creating like a discharge summary so that when an order was submitted for a social need, that the patient's discharge summary would include all of the local resources, or at least the contact information for them automatically. Did that happen, or was that an idea, or do I have the wrong team? Did you explore that at all?
I don't believe we did, no.
Okay.
Yeah. We're trying to process everything through like the orders, and then like myself, and then whoever we hire will do the referrals.
Okay, that makes sense. All person rather than printing. So, and Amy also, so Amy, if you all don't know Amy Vassarino, she's our APCM program manager, and she had asked to join today. I feel like I should have done the introduction a little earlier. Sorry, Amy. So she's really excited that you've incorporated care steps into this. And I'm calling that out.
Yeah, our QI team's really excited too.
Do we have any other questions for Aviva and UHA before we move on? Okay, thank you. We can go to the next slide. And next we have Virginia Garcia and Care Oregon.
Hi, Courtney. Kendra here from VG. And I think I'll be taking the slides. So go ahead and go to the next slide. And Ashley, I see you're on the line. So if you have anything to add, please jump in. Our team, here's our team. It hasn't changed. Go ahead to the next slide. So for us, I don't know, I think I was thinking a kind of abstract in some of our best practices, because we actually really struggled with implementing the Z codes. So a lot of our work was around what we could have done, what things may have looked like. So I think for us, some of the best practices that we identified was including key stakeholders in workflow development. So we did include direct care staff as well as our data analysts in developing workflow concepts to ensure that we could extract the data that we were trying to pull, and also that it would work for the folks in the clinic on the ground doing the work. And then the other one was just to celebrate small successes. We hit a lot of hurdles in this project and trying to get things moving forward in the way that we hoped. But I think our partners at Care Oregon also really helped us reflect and celebrate small wins and small successes and what we were able to accomplish, which I think is important in the time of in the times that we're in. Next slide, please. Looking back, I think this has come up for us just generally around the work with social determinants, that identifying support from our operations side prior to implementation would have been really helpful. I work in our mental health behavioral health department, and I supervise our community health workers that are embedded in our clinics, and they're the ones kind of boots on the ground doing a lot of the work around social determinants. But as we keep engaging in this space, we continue to identify the need to include other clinic staff, and those folks are under like a different part of the organization. So it just kind of speaks to some of the silos even within our own organization. The operations side has more influence in the clinic workflows when we're talking about medical assistants and other care team members. Our CHW program is pretty small, and they're really focused on navigation around those social needs. And so we had identified, medical assistants or other care team members might be a better fit for documenting Z codes, and any changes to workflows there would have to come through operations. Next slide, please. I think that it looks like that's the same. We're on the same slide. Oh, there we go. And I think this probably resonates with a lot of folks. Our greatest barrier is just competing priorities at an organizational level as the work continue to pivot and change, and that most of our clinic staff were shifting into supporting vaccine clinics in recent months. And so it's just kind of put a halt to any changes to workflows in the clinics. And then for the community health workers that have been engaged in this work, just bandwidth to participate. Our organization also has some kind of competition around like projects for social determinants, so multiple projects within the same or similar themes. And so just bandwidth and capacity are probably our biggest barriers. Next slide, please. Thanks. For us, this is a question mark. We, like I said at the top of it, unfortunately, we haven't really been implementing, documenting the Z codes. So we were starting to think about what are the pros and cons. And there are a lot of pros that we identified. We feel like it aligns with our goals around patient segmentation. We like the visibility for the primary care providers. We hear them say over and over again, if it's not on the problem list, I don't see it. So they like the visibility, possible future incentives and preparation for metrics. And then from the data side of things, the ease in running, Kavita wanted to mention, the ease in running reports, and again, around the supporting aggregating data for analysis. So I think there's a lot of pros. The harder parts for us are like responsibility around resolving it. So if we're adding something to the problem list, when are we identifying that the problem is resolved, and kind of that cadence or frequency for review. So on the one hand, we have PCPs saying they want to see things on the problem list because if it's not there, they don't see it. But then there's a little bit of tension around like ownership of that space. And just the documentation component. It's exciting to see some of the ways folks have streamlined this work. But I think for us, again, just those competing demands of like, we're documenting in a flow sheet, and then we're documenting on the problem list, and then maybe we're also going into another platform like Connect Oregon, Unite Us, and documenting there, plus the regular notes. So just trying to identify ways to streamline it. So we have a question mark, but more to explore. Next slide, please. Yeah, and for us, for next steps, we have been tracking the surveys that we're administering. And again, we kind of did that look back of what would it look like if we had documented the Z code. So we're certainly continuing to move forward with administering surveys. And we're still hoping to implement a workflow around Z codes. I feel like we've learned a lot through this process, and it gives us there's like a work group forming at our Hillsborough clinic. So I think there's opportunities for us to continue exploring this space through what we've learned in this time together. And I think that's it for us.
Thank you, Kendra. I love that you've put the pros and cons, and also I think it really says a lot that they're, and I think this has been true across so many of the clinics, that this work is really hard and this year is really hard, and people are really burnt out, of course, too. Like it's really hard in a crisis to be thinking about billing and coding and innovation, and so I want to call that out and just say like yes to all of the things you said, and also I think it also really speaks volumes that even though that you haven't found the team and the workflow yet, that you're still really pushing for this, and that you want to see what it would look like, even if ultimately you don't decide to go in this direction, that it's still worth a shot despite all of the barriers. And I think that's really awesome and good to call out. And then another reflection too is that something you had said, that Care Oregon was there to help celebrate the small successes. I just want to say how important that is too, that like this is a working process. And our partners on both the clinic and payer side, are united in this mission. We across the whole system will benefit from having this information, and all of the patients and members will benefit. And this is teamwork, and sometimes we got to support each other through it. And I'm just really glad that you said that. Okay, so enough of me talking. Does anybody else have questions or reflections from the BG and Care Oregon project? Okay, I'm gonna move us on to the next team. Again, we will have so much time to reflect in our final webinar and also a little bit more today. So if something pops up for you, please put it in the chat or bring it up at another talking point. Next, we have Wallace and Care Oregon.
Hi there, this is Lydia. So you can go to the next slide. No team changes. I believe Nikki and Sarah Jade are also with us. So please, Nikki and Sarah Jade, and I think Ashley too, if there's anything else you want to add to what I have added to the slides, please jump in. Next slide. So best practices. The first thing that came to mind for choosing best practices was thinking about just how to select the first few Z codes that you want to use when testing just Z code use in general. And I just thought it might be helpful to mention kind of like things that we considered or talked a lot about for a long time before choosing the 3 Z codes that we chose. The 3 of which, as a reminder, were the homelessness code, the problems with housing, so 2 housing codes, and then the food insecurity code. And so the 3 main things that we talked about were, are the resources available for the ones that are, do we have housing? Do we have food available? Because we didn't want to choose codes that had, would basically need resources that we don't have a lot of right now. So that, and also high needs obviously is a pretty big one. And also what kind of data do we need? Where do we need better data? And that really weighed into a lot to talking about the housing codes. We need a lot more accurate data on people that are homeless or at risk of homelessness. That differentiation I think is really important. So that was talked a lot about. And then also, I think it really helped that we already had a pretty solid foundation for screening. I don't know if that's necessarily required for doing Z codes. I think that those both could be done in tandem as a brand new project, if that's what needs to happen. But already having that screening in place helped us. It just was easier to integrate the Z codes. And also having really detailed instruction documents for our patient navigators to do the data entry and all the follow-up and outreach, that seemed to help us be successful. So next slide. So looking back, we should have, I think we would have benefited from having some more formal training for staff. I mean, we also had some restructuring happen just before adding Z codes to the duties of patient navigators. So I think our training was just kind of all over the place when they were hired. So that would have been nice to have just a better system for that. We also don't yet have a full-on policy procedure for screening for social determinants of health. That's something we're working on now, but that would have been nice to have like a better description of what our overall goals are. And then yeah, also I guess I'm listing things that we're working on now that I would have liked to have had before. So one of them being, we right now only are screening through paper screeners through, we send them in the mail. So, and receive those back either in person if the patient has an in-person visit, or they mail it back. So that screening rate, we're about 30%. And so we're hoping to maybe increase that rate if we can just expand our routes for screening, maybe through MyChart, maybe through phone calls, but basically not just paper screeners. Sarah Jade or Nikki, do either of you have anything to add so far?
Nope, nothing to add.
Cool.
Yeah, no.
We can go to the next slide. Barriers, clearly plenty of COVID barriers. As I mentioned, we had a staff restructure. We also recently moved our clinic physically, so that's been a little bit of a bump, but yeah, basically we're still recovering from having to kind of adapt a lot of workflows into virtual workflows, and patient navigators being newly hired and overwhelmed with competing priorities. So all the same stuff that we're all experiencing. Next slide. So we definitely will continue using Z codes because of a lot of same reasons that all of us have talked about a lot through this whole collaborative. So I imagine it mainly as really helping to create standardization of this data. I know that it could also contribute to risk stratification. And the biggest thing that I find myself talking about a lot, which maybe I'm a broken record at this point, but helping to promote just the normalization and the destigmatization of the impact that these factors have on patient health outcomes. I think that's a really huge one. We want to help the screener seem similar to other medical screeners and happen just as regularly. And then also eventually help contribute to making visits with care team members like CHWs and patient navigators, making those billable, which also helps those roles be recognized as very credible and experienced and trusted to do their jobs with patients to help them get resources. So is there another one on the slide? I don't remember. Next step. So we definitely want to work on increasing our screening rate. We've yet to talk or have more discussions around sharing data with Care Oregon, and then maybe talk about adding Z codes. That's hasn't come up quite yet, but we also have a DNP student that's going to be joining us soon to help with specifically SDOH, our overall project. So I'm really excited about that. That's very new, but we've got a lot of work ahead of us, and I'm feeling optimistic. So I think that's it. Thank you.
I have plenty of things to say, but I'm gonna open up the floor. Does anybody have questions or reflections for our Wallace team and Care Oregon?
So this is Sarah Jade. I was just going to say that we had done a bunch of work in this area right before COVID happened, and we had been doing piloting with really integrating having the patient navigators working with the patients when they're coming into the visits, and we had done a lot of work around that. Lydia and a team of folks had done a lot of work around that, and I feel like it all kind of got derailed with COVID, but it's really exciting that we're going to be getting back to that place, and I think this is going to fit right in there. And we have this really good foundation for that. We have these learnings that we had. I distinctly just remember this last quality meeting we had before COVID started, where we were talking about how this was working for our provider that we were piloting it with. So I feel like it's really good that we're feeling like we're going to be able to get back and have those learnings have a solid foundation for moving forward.
Yeah, that's a really important reflection. And I'm happy that you used the word optimism. Like, I think just hearing somebody say that they're optimistic makes all of my feelings change, because we're not hearing so much of that this year. So that was really great. Also, I do want to call out, Lydia, you said that you have a DNP student joining, and I really like to emphasize every time I hear a provider role mentioned with this work, because it's something, and I know you are not the only team having providers focus on SDH, and that we do have a lot of really amazing providers who care about this and prioritize this. But having been in a non-provider role in a clinic pushing this work, I know, I hear a lot of the tension with social needs and healthcare and roles and ownership of the problem list and kind of all of these things that we wrestle with in the clinic environment. So I would love to hear how you plan on using that role and kind of what you're envisioning.
I like the question. I mean, I've met with her so far, and of course, I'm not going to speak I'm trying not to speak too soon about, my perception of what we could get done, because it's it's still so fresh. But I mean, in a way, I will say it feels a little bit it feels a little bit silly to have to need someone with additional experience to be able to bridge that gap. I do think it's going to work to our advantage, and I'm definitely not by any means against it. I'm excited to have a partner in doing the work, like just another set of hands, another brain that can work on getting it done smoother, and just be another voice to help lift up what needs to be done. So that's the perspective I'm trying to highlight, is that one, instead of it's too bad that it takes this to have to, make some changes. But I'll just say that much. It helps when the person who is coming on board to do that work is considering themselves a supplement instead of a replacement, or someone who's trying to, steal the show or something. I think there's a natural fear, I think, that could come from an organization about that person stepping in. So I don't feel that way at all. I think this is going to be just more support, which is wonderful.
Yeah, thank you, Lydia, for going through the thought process, because it's no secret that clinical organizations are very hierarchical organizations, and they've been built that way for reasons, but social needs fitting into that space is tricky sometimes, and we kind of have to wrestle with how it all fits in. So thank you for saying that. I'm gonna move us on to our last but not least presentation, and that is Reinhardt and CPCCO.
Okay, hi everybody. This is Denise with Reinhardt Clinic, and we have some of our staff, Katie Sollenberger's here, as well as other members of our CCO. So I'm going to start off, and our CCO team can chime in wherever needed. So next slide, please. So we've had a really great time working closely. Our team on the quality and outreach side is myself. I'm a nurse and quality director, and Angelica Godinez is our outreach and enrollment navigator. And she has been the key role in starting SDOH work a couple years ago. So she's been impactful on this pilot. And Katie Sollenberger is our data guru and IT specialist. So she has really been a huge part of this for the data side of things and implementing with OCHA and Epic. And our CCO team, Keisha, she just had to step off to another call, but she has been our organizer and making sure, prompting our team for getting things done or setting meetings. We really have been driven by her leadership, so I really appreciate her keeping us going. And Nancy Knopf and Heather Oberst have both been a huge integral part of this work, meeting and brainstorming around the member perspective and the system perspective. And we just can't say enough good things about our CCO partners. Next slide, please. So the best practices, really what we've focused on is involving the team members who are doing the screenings in all stages of implementation, because as in most QI efforts, what you plan on and set for and think you have figured out, you have to be flexible and adapt in really utilizing that PDSA mentality of checking back in with those doing the work and finding out how things are going from how we planned it in the actual actionable stage. And really, our MA team has been engaged and involved in this work, and we've even onboarded a new MA during this process. And looking at the data, she is right in line with the rest of the team doing the screenings, documenting. And so that always gets me excited that it's becoming a standard part of workflows. The other best practice the CCO and Reinhardt focused on is building patient consent and really feeling responsive to our members and patient panels when we visited with our Patient Advisory Council and our CCO Community Advisory Council, hearing very differing opinions of how people felt having the social needs results as part of their medical record and having the Z code included. And by asking, we're really getting members' feedback, and we're not seeing a lot of declining, but we do feel it gives people empowerment to learn about these screenings and learn how they're impacting health and become more comfortable. I think I've talked about this in prior presentations that we really feel like this models the depression screening and follow-up that used to be maybe 5 years ago brand new to healthcare. Like, why are you asking about my mental status and my mental health during physical health appointments? And now it's a standard. People are like, oh yes, there's that screening I get every year. And we're really hoping to approach it in this trauma-informed way of asking people if they wanted a part of their medical record, with the hope that in a year or two, it'll become standard care where people are just used to the screenings and are fine with it being part of medical record. Next slide, please. So looking back, what we should have done, it's always easy to look back and think that, is in the beginning, we were really good about monthly MA check-ins where we would hear directly from them what's happening. And we heard from them, you know, around the Z code implementation, we had 3 Z codes and they said, no, we're seeing these other 2 Z codes more often. Can we use those? So we expanded from a pilot of 3 Z codes to 5 Z codes. But what we found, which a lot of people have shared, the COVID vaccination rollout, we took a bigger role than we thought we originally would by having an off-site vaccination pod weekly. That really strained our clinical team, and the focus had to be on that. So we continued with the screenings and continued with the 5 Z codes, but we do need to restart monthly meetings with the MA team, because that's where we were hearing direct feedback and making changes to our plan. And then I think we could have anticipated the slower progress due to the COVID crisis. We set our targets and goals high, but CCO and the clinic really have rolled all support towards COVID vaccine rollout, rightfully so. But we are seeing that kind of start to decline. That will be returning to the clinic only for our vaccine pods here in the next couple weeks. Next slide. Our greatest barrier, we still continue to see a lower positive result than we anticipated. And some of our theories around this is, are we asking this in a way in which people feel comfortable sharing their needs? So we want to explore that, and we want to do some trainings around how we ask these screenings and see if that can impact anything. And as others have said, COVID has been our biggest barrier. Just with one thing after another, you think you're kind of in a lull with COVID because maybe the positive cases are less, but then vaccine rollout. And we thought we were wrapping up vaccine rollout, and then Pfizer's available to 12 to 15. And so then the CCO is busy with outreach and we're busy with the vaccine pod. So there's all these things that we all are sharing and going through. Next slide. Whoops, here we go. Yes. And so we do plan on continuing to use Z codes. We see, looking at our Reinhardt data and looking at the CCO data, that claims are coming through. Our next step of the process really is fine tuning. Do we want to add more Z codes? Can we work with specific users who are not using Z codes? Really getting into the monthly team meetings so we find out who our high performers are and who our low performers are, and how can we continue to move the work. So we know it's happening, just not to the level of what we would like to see by this point. And I already talked about COVID enough. Next slide, please. So our next steps, we're excited. We're going to meet with our CCO team in June here, and really looking at the CCO pulling their data and Reinhardt Clinic pulling our data. Because if you remember, Katie has worked with OCHIN to really get us reporting processes in place where we can get data for the pre-screen. So not just the positive screens, but every pre-screen that we have. Oh, and Keisha's still here. Wanted to add that there's some interesting nuance to this work when it comes to small communities where everyone knows everyone. Yeah, so we felt this concern around privacy in the Unite Us rollout too. And I think that's a really great point. And Reinhardt's also very interested in the Unite Us platform, and that was kind of one of our target goals, big picture goals. And just with staffing and capacity, we haven't had the chance to implement with that. But when you're looking at a community of 3,000 people, there really is that concern about protecting people's privacy and making sure that the information shared, that the patient feels comfortable about that. So the next steps, we're really looking at getting our data from each side and pulling together and seeing what does our data say at Reinhardt, what does CCO's data, are there any missing pieces to how we're documenting? We also have a few testing things that we haven't done yet, our closed loop process through our EHR, and then also expanding to a telehealth visit setting. I'm sure a lot of you see this, that telehealth is not going away. We still find at Reinhardt 30 to 40% of our monthly visits are via telehealth. And so we know that's still a part of care, and we haven't rolled out how to do the screening in telehealth yet. We want to do an all staff trauma informed training just around how we ask questions and how we, the language we use and the impact that has. And then that will hopefully lead to looking at our positivity rate. We have seen some increase over time. It was very low, less than 5% in the beginning. Now it's closer to 10% positivity. So we are moving in the right direction, but we also want to see, during this time, we would have expected to see much higher positivity rates. So our next steps really are getting back on track with our monthly check-ins with our team internally, and then every other month check-ins with the CCO as they really keep us moving forward. And that's all I have.
Thank you so much, Denise, for sharing all of this. You all have done amazing work, and I really appreciate the detail that you've given with the next steps, and just all of the things that are still unknowns. And I just want to call out that a year is not that much time in the clinic world to make a huge change like this. It's not a long time to make a huge payment change either, or even pilot that process. It's not a huge time to establish a different relationship with your patients either. Like these are, these things take for a really, really, really long time to implement. So I think I've heard from everyone this kind of consistent, like, we wish we had gotten further, and we'd hoped we'd be here, and we set these high goals, and it's like, actually, this has all been amazing, and these things are really, really, really time consuming, and getting huge groups of people on board with anything is hard, regardless of how much it impacts their work. And this does impact everyone's work and time and everything. So I will stop rambling. Does anybody have remaining questions or reflections for the Reinhardt and CPCCO team?
This is Heather, and I just wanted to add that this feels like the conversations we've been having with the Reinhardt and that we're going to be having with the Reinhardt are just, they're also incredibly well timed, because I'm starting to hear our community-based organization partners really start asking about things like social needs screening, and because we've been rolling out Unite Us or Connect Oregon, kind of how do we really become a full network that is inclusive of all of those partners. And so it's been really cool to kind of have learnings from our partnership with the Reinhardt to kind of say, these are some of the things that we're starting to think about. These are some of the conversations happening at a state level. And look at this really great local example of how we are able to kind of test this out and think about it in a trauma-informed way. So it's been really cool to see that kind of start to converge at the time that we're closing this out.
Yeah, thank you for sharing that. And also, as a reminder, in this the OHA SDH metric development this year, the one that's in pilot testing, the main reason that everybody went with the first measure concept, which is screening all members using any data source, not just in claims, not just Z codes, not just EHR, but any data source, was so that CBOs and other community partners could help to send this data to CCOs. And in the pilot development right now, they're really feeling like the CBO voice is missing. So if you do have CBOs that are engaged or thinking about this, definitely encourage them to join the TAG meetings, because their voice is wanted. And I think OHA is really saying that they're in a position to listen to what CBOs are saying right now around metric development. So yeah, just a reminder, please encourage them to speak up about which aspects of this process will or won't work for them. Does anyone have any remaining questions before we head into a 10-minute break? I don't want to dangle the break carrot and and have people not ask questions. So please, if you do have questions, speak up. Okay, I will move us on. Thank you so much, Reinhardt and CPCCO, for all the work you've done, and also for presenting for final time today. And we've just wrapped up our team presentations for the collaborative. So thank you all for all of the amazing work you've put into these slides. I know that they can be agonizing and that you have a ton of other stuff going on, and you don't need one more thing from me to fill out, but you did it anyways. And thank you very much for making so many team presentations throughout the collaborative. That was your last one. So we're done with the PowerPoints. Next slide. We're gonna take a break for 10 minutes. So I will see everybody back here at 10:19. Go take your bio break, step outside. It's not super sunny in Portland today, but if you need to just go get some fresh air, I encourage you to do that. Refill your coffee, do what you need to do, and we'll see you at 10:19. Okay, everyone. It just hit 10:19. I'm going to keep us moving so we have enough time to do the surveys. I hope you all had a refreshing break and that if my voice has just pulled you out of that, that you're coming back and joining us. Next slide. So I think most of you will remember, I know individuals and teams have changed a little bit over time. So if you're not aware of this, I'll give a quick review. Back in June of last year, the OPCA team introduced a pre-project survey, and it's like 15 to 20 questions, depending on how you answer. And they were to really evaluate where everyone is at right now, or in the current moment with social needs data sharing, social needs screening, and the relationship between FQHC and CCO. So they were collected between June 25th and July 17th of last year. And we're tracking these by organization, not by individual. So we had 4 CCOs respond and 7 CHCs. These are some of the slides that were presented to you all with this data, if that helps to remind you. So these are some of those sample questions. Next slide. And because we're not necessarily done with the collaborative, but you all have reached the end of your pilot project, we're going to do your post-project surveys. And they're the same questions. We're using a different tool. We're using Microsoft Forms this time, but they're the same questions. We're going to collect 1 survey from each organization. And I'll share the links in the chat in a moment, but the CCO and CHC surveys are slightly different, very similar questions, slightly adapted to your different organizations. The process that we'll use is we're going to do breakout groups by organization. If you're the only one on right now from your organization, we're going to hold you in the main room for a moment and talk about it. But if you are in a group for this survey, we're going to ask that you only submit 1. And once you're in your breakout group, choose 1 person to share their screen and they can kind of fill it out live as you all discuss them. You'll have about 20 minutes to complete. I'm not sure that it will actually take you 20 minutes, but you have 20 minutes if you need it. And return to the main room once your survey is submitted. And I'm going to share the links in the chat right now. Just be sure that when you're pulling this up, that you are in the right one. So if you're a CCO, make sure you click the CCO link. That's the top one. If you're at a CHC, make sure you choose the CHC link. That's the second one. Does anyone have any questions before we put you into breakout groups? And I will pop around and make sure that you're set up as well. Okay, I'm not hearing anything. You can also feel free to chat me or Malia if something comes up for you. Some of the questions, I think it's only like 2 of them, are about barriers. And I know you all just talked about that. It's important for us to be able to capture it in the same format we did a year ago for measuring change. So thank you for answering some of the same questions again. We also felt like it was really important for you all to discuss those barriers with each other and present on them and learn from each other as well. So sorry for the repetition. Next slide. And with that, if you are not the only person from your organization here right now, you're going to be sorted into a group. And I'll give Malia a moment to do that. Okay, for our folks um, who are here right now. Tell us what you would like to do. Would you prefer to just camera off, mic off, have a little work session for yourself to fill this out right now? Or would you prefer to be sorted into like a CHC group and CCO group? How do you feel?
I think I would prefer to go be with the Reinhardt.
Okay. Heather, you're at CPCCO. So so my only concern with that is we do have relationship questions in. So, and we'd like to give them the opportunity to give honest answers. Sounds like they've said times that your relationship is great. But with that being, I want to give them the opportunity to, if they're going to answer, I don't know.
Totally.
You know what I mean? Just from a data perspective, I don't think they will. Would you, Tanvir and Heather, would you like to work together in your own group? Or would you rather just kind of fill it out here?
Do we have to kind of consult with each other, or you feel like that'll be more beneficial?
It's up to you.
Okay, I'm fine, either way, but yeah, I just got it off. How many questions there are total?
It's 15 to 20 depending on how you answer. So like there's some branching that if you answer yes, then you kind of have an extra question popped in. Okay, so I will have you guys and gals and non-guys and gals, however you identify, fill it out on your own here. And if you have questions, let us know. I'm gonna pop around to the other groups to make sure everyone's all right, but I'll be back in a moment. Okay, welcome back, everyone. It's nice to see your faces. Hi, even if only for a moment. Okay, I'll move us on. Maybe we'll have a few minutes left at the end. Next slide, Leah, thank you. Okay, so yes, the pilot project and workshop portion of the collaborative is over, but we still do have 2.5 months left. So at the end there, June and July, we're going to have one event in each. And I'll take us to the next slide. So the June webinar is on June 22nd. It's from 1 to 2:30 p.m. and it's another one of our state webinars. So initially we had planned to do this webinar earlier in the spring, but due to vaccination rollout and capacity, not just here, but everywhere, we decided to push it to after the last workshop. So we'll be hearing from David Di Giuseppe, I think is how we say his name. He's the Vice President of Healthcare Economics at the Community Health Plan of Washington. That's an MCO, and they have built in Z59 into their social risk adjustment model. So we've asked him to come and present, show us what risk adjustment model they're using at the CCO. I don't think he will go into a ton of detail about contracting with individual FQHCs in his region, but he has said that he will look into how it's affecting cost utilization. So hopefully he's able to share some of that. And then we'll have one final webinar in July, and that one's not scheduled yet. We still have a few details to figure out, and that's part of the Menti questions that we'll do in a moment. So we will review the post-project survey results. We're going to compare the overall responses from all of your organizations from the beginning of the collaborative to the end. Hopefully we will have the final report done to share with you all. So we're going to create a toolkit and a write-up on everything we've done, and we'll have that to share with you. We'd like to figure out a way to stay connected with each other. So I need to think about that over the next month or so. I may be reaching out to individuals to see what you would like to be contacted about, if at all, and maybe we can create a little bit of a directory so you all can continue to learn with each other and share ideas. And of course, more reflection and celebrating the success of this year. Small to large, there have been many, and you have all been really creative, and I'm just completely blown away by how cool this was. And after just joining OPCA, this is like the best project that I could have had coming on. So I know there have been frustrations along the way, but I've loved this, and I hope you all have too. And let's celebrate that. And then finally, you've heard me mention Oregon stakeholders a few times, especially with the mural activity that we did at the last session. So many of those stakeholders are actually on the advisory committee for this learning collaborative. So that includes CARE Oregon, OCHIN, that includes OHA, Kaiser, ORPRIN, and many more. There's so many different organizations that have joined on to the advisory committee. A few of you all have made presentations to them, so you've met that group. But in our last advisory committee, we mentioned potentially combining the final webinars to give you all a chance to engage with each other. But this is your final webinar, and that's your time. So it's really only if you all want that, and that will be a question in the Menti that we'll do in a moment. And next slide. And before we do the Menti, I'm going to hand it over to Stephanie because she's running a related project that you all might be interested in.
Hi, Courtney. Hi, everyone. Thanks, Courtney, for giving me a little bit of space. I just wanted to bring your attention to a new peer group that OPCA has for its membership. It's on CHW integration. We kicked it off in March of this year, and it's really a group for health center staff who are responsible for really integrating, supporting, lifting, expanding the CHW role within their clinics. So you can see a little bit information about the peer group here and some of our objectives. Our next peer meeting is on August 19th, and we are convening a group of CHW advisors. One of our main objectives is to really lift and carry the voice of the CHW workers as we think about CHW integration. It's a voice we definitely want to have leading this peer group. So if you have any CHWs within your clinics who think could be a great advisor so far, I think we have representation from Multnomah County, Northwest Human Services, Coast Community Health, and maybe I think another one that I'm forgetting right now, but please feel free to contact my colleague Therese Cook if you're interested. I also prematurely put in the chat our one pager for this peer group. I wanted to make sure not to forget it as I was speaking, so you'll find more information about this peer group in the chat in the file that I just shared. But that's all I wanted to share, and I wanted to say thanks again, Courtney, for giving me some space to share about the CHW group.
Thanks, Stephanie. And I was able to attend the first session. It's really awesome. If you're curious and not sure, join. It was excellent. Okay, I'll take us to the Mentimeter now. So Malia, were you able to pull the Menti up? Oh, sorry, thank you. And I think everyone has used Menti at this point, but you will need to pull up another browser or have your phone to participate in this poll. I'm sorry for all of the questions today between the post-project survey and the Menti. I hope it's not too much. So the way that you join this poll is on your phone or on your browser. Go to www.menti.com. That's spelled MENTI.com. Use the code 5480358. And that's both at the top of the slide and in the chat. And our first question is, would you like to engage with Oregon stakeholders, aka our advisory committee, during the final wrap-up webinar in July? And then Malia, if you highlight over the question, and you should all see this on your screens as well, there's a list of some of the organizations that are part of that advisory committee. And the options are, yes, they can listen the whole time. Yes, but I want them to only join for discussion. I don't want them to listen in to what we're saying the whole time. No, or other. And if you have a different idea, please share. Okay, I think that's everyone. We can move to the next question. And beyond the list I just shared, what else would you like at that final webinar? So not the state webinar with Washington, but our final webinar. Is there a certain method of celebration you would like to see? Is there, does that directory sound nice? If we could get, or as many individuals are willing to be on a directory for each other. Is there specific questions that you really want focused on for a discussion with those Oregon stakeholders? Are there things you need to know from them that you want to make sure that I ask? Of course, you can ask too, but I can emphasize it and raise it up if you want me to. I'm seeing donuts. People don't like donuts. You better add something. I'm actually not sure. I'll have to check with OPCA if I can get donuts for you all. We'll see. I love that though. I like donuts. The collection of best practices. Yes, best practices will be in that report for sure. Absolutely. Follow-up check-in at the end of the year. Yeah, we can gauge interest in that at our final webinar for sure. And I think we're down to 9, so we can move to the next slide. What did you like about using Mural? So we do have a follow-up question on what you didn't like, but what did you like? Yeah, seeing all thoughts and comments in real time, that's the biggest one for me, is it feels really conversational. Like I love. And I'm gonna be mindful of time and take us to the next slide. Sorry, I'd hoped I would get you all out of here early, but that's all right. How could OPCA use Mural better? Is there something, this is a very new tool to us, so any thoughts, feelings, strong convictions, even all of it, we'd love to hear it. No way we got it perfect on the first try. Yeah, the layers, that final answer, number 1, that was my fault. Sorry, everyone. Can be overwhelming when you first look at it, for sure, complicated. Okay, thanks everyone. And when I move on, you can still complete, it's set to audience pacing. So if I'm moving on too quickly, it shouldn't pull you out of the question you're answering. Next slide. How would you rate your satisfaction with the May workshop? And these are our standard evaluation questions that we do at most of our events, the ones that are coming up now. Bye, Lydia. Thank you. Sorry, I know we're approaching the end. I'll take us to the next slide. Move through these fairly quickly. How confident are you that you will be able to apply information from the May workshop to your work? I think that's everyone now. What 1 to 2 things did you learn during the May workshop that you may apply? I think the next 3, or this one and the next 2 are open-ended. So sorry that those all came at the end. And next question. Thank you all for staying on an extra minute. We understand if you need to go. What are 1 to 2 things related that you need to learn more on, or that you need to move the work forward? I know this has been asked a few times today. This is a HRSA question. So sorry for the repetition. And that is basically our last question. There's one more at the end. If there's something that you would like to add that was not covered. Thanks, everyone. That's nice. And this is it. So thank you for dealing with any survey fatigue in the last 45 minutes. I know it's a lot of questions. We really appreciate you being here and all of the amazing work you've done, and we will see you again on June 22nd.
Thank you.